everyone, and just to give you a little background on myself, I am a registered nurse, also a registered dietitian, and a registered certified diabetes educator. So you have to excuse my cold. I have a lousy cold, but we'll get through this. And the first what I'm going to talk about here is what is diabetes, what are the types of diabetes, and what are possible complications of diabetes. I talk to people all the time, I have diabetes, so what is it, what do I do? I see people, I work at Hackensack Medical Center, and so I see people all the time in the hospital with this. Diabetes is a disease when the glucose or blood sugar is elevated. And glucose comes from the foods that we eat, primarily carbohydrates. You'll hear from the registered dietitian later that protein really doesn't have an effect on blood sugar, fat really doesn't, but carbohydrates become sugar in our body. Insulin is a hormone made by the pancreas, and the job of insulin is to take this glucose into our muscles and cells to make energy. So this is a great diagram that I use in even classes to show you that, like for instance, if somebody just ate a little donut or something like that, that is a carbohydrate. That breaks down into sugar in our body. And so that sugar goes into our blood. That causes the pancreas to release insulin. And what the insulin does is it unlocks these little receptors on our muscle and cell walls so that the sugar can go into our muscles and cells and make energy. So diabetes happens when either the body doesn't make enough insulin or that the insulin doesn't work very well. So then the glucose stays in our blood, so our blood sugar is high. So again, it's either this picture of the pancreas does not make any or enough insulin, or at the muscle and fat cells, it does not use it effectively. So how do we diagnose diabetes? Well, first of all, if you're in a doctor's office, not in a hospital because stress raises blood sugar, but if you're in the doctor's office and you had a fasting blood sugar, it would be a blood sugar of 126 or higher. A lot of times they would want to call you back. If it was just on the border, they'd want to call you back maybe in a few weeks and retest it. The other way is a hemoglobin A1C of 6.5 or higher. Now I'll explain a little bit about the A1C later on, but the A1C averages a person's blood sugar for the last 2 to 3 months. And there are over 30 million people in the United States that have diabetes. It's an incredible number. Pre-diabetes, sometimes people say borderline, it's called pre-diabetes. And pre-diabetes is when blood sugars are elevated, but not at the level of diabetes. So how do we diagnose that? It's a fasting blood sugar of 100 to 125. A lot of times at that, the doctor may ask them to watch their diet, exercise a little bit more, and come back in a few months. But the other thing they could do is do a hemoglobin A1C, because that's actually even a little more accurate, because the hemoglobin A1C takes into account after dinner blood sugars, after meal, which are generally higher. So an A1C of 5.7 to 6.4 is pre-diabetes. And unbelievably, there are 84 million adults in the United States that have pre-diabetes. And when you think of it, if even half of these people develop diabetes, it's an epidemic right now, but the public health problem in our country. But the good news, we talk about pre-diabetes, is, well, I'll talk about it afterwards, because there's actually very well-documented treatment of pre-diabetes. But so who is actually at risk for diabetes? Well, age. So some things we can't change. 45 or over. Being overweight, that's something we can change. Having a parent, brother, or first-degree relative with type 2 diabetes, very strong predictor. Having gestational diabetes, about 50% of all people who have gestational diabetes move on to diabetes. And race is absolutely a risk factor. I talked about pre-diabetes and diabetes prevention. So about over 10 years ago, there was a study that was done with tens of thousands of people who have prediabetes. So they wanted to see, is a medicine called metformin better, or can diet and exercise better? And they actually stopped this trial early because the results were so overwhelming that diet and exercise is the best thing to delay or prevent type 2 diabetes. And what they found simply is if a person could lose 7% of their body weight and walk, exercise, light exercise, walk 150 minutes a week, that was more effective and more powerful than a medication called metformin. So that's really significant. I also I see people in counseling as a dietitian as prediabetes, and I see myself, we can get their A1Cs out of prediabetes levels by just that weight loss and encouraging people to just start walking and everything. So that's the exciting news about this. So, what are the most common types of diabetes? Actually, I went to a conference in Baltimore, the National Conference of Diabetes Educators. There's about 10 different types of diabetes. But I'm going to talk about the 3 most common types of diabetes: type 1, type 2, and gestational. So, type 1 diabetes is when a person's body, their pancreas, does not make any insulin. That's weird. Okay. They do not make any insulin whatsoever. It is generally diagnosed when a person is younger, under the age of 21, but actually we see adults who are diagnosed with type 1 diabetes. And as I said, a part of their pancreas, the beta cells that make insulin, is destroyed. And they no longer make insulin. And a person with type 1 diabetes has to take insulin for the rest of their life. And what happens is that they are not sure. There are some gene variants that can cause type 1 diabetes, but the primary cause, it is felt, is that viruses, enteroviruses like a Coxsackie virus, which is very common. I mean, my own granddaughter developed Coxsackie. She's in childcare when she was 6 months old. So enteroviruses, some stomach viruses and everything, and repeated viruses like that are thought to make the body work against itself and cause type 1 diabetes. Type 1 diabetes is considered an autoimmune disease. So, and in fact, people with type 1 diabetes are absolutely more predisposed to other autoimmune diseases like celiac. All children with type 1 diabetes are screened for celiac automatically. So now type 2 diabetes, that's about maybe 90% of all people with diabetes. And so characteristic is it generally occurs after the age of 30. They used to call type 2 diabetes adult onset diabetes, but we don't call it adult onset diabetes anymore because, as I said, children and younger people are developing it. And with type 2 diabetes, actually in the beginning your body is making plenty of insulin. That's not the problem. It's that the insulin isn't working well. It's called insulin resistance. And so this actually sometimes causes the body to keep on making more insulin, pumping out more insulin, and the insulin just isn't working very well. So the glucose cannot get out of the blood into the cells, so it stays in the blood, you have high blood sugar. So type 2 diabetes actually is a very slow process. It can go undiagnosed for 5 years or more because you don't feel, just like sometimes when you have high blood pressure, you don't feel high blood sugars. So heredity plays a major role. We were talking about all those risk factors, heredity. The other thing that plays a major role is extra weight, especially around the middle. And when you have that actually causes that apple shape versus the pear shape is not this kind of fat. It's called visceral fat. And it actually releases hormones and chemicals that cause insulin not to work so well. Stress, it's so complicated, like what causes, but stress absolutely. We see people in the hospital and they'll say, my blood sugar was never this high. And I said, well, one of the things, Mentally, you're stressed because you're in the hospital. Physically, you're stressed because you're sick. And you're not as physically active. You're either in bed or in a chair. So, gestational diabetes. Diabetes that develops during pregnancy. We usually test for it within 24 to 28 weeks of pregnancy. What happens is that the placenta produces hormones that cause this insulin resistance. And if it not treated, the blood sugars remain elevated and it can cause complications for both the mother and the baby. And again, the blood sugar returns to normal. As soon as the baby's born, the blood sugar returns to normal. But they're at an increased risk for type 2 diabetes later on in life. So pregnant women are usually screened at between 24 and 28 weeks. And this is just, I put in for your information in case, but they used to do these 1, 2, and 3 hour glucose tolerance tests. Now they do one glucose screening. You take 100 grams of glucose and then they test blood sugar levels at these time intervals, and that's how they can make a diagnosis. So, with gestational diabetes, yes?
Just a comment on it. Our participants are required to test their blood sugars all the time.
Yep.
And usually they're okay. They don't have to take any medication unless their blood sugars go above 200, which mostly they don't.
Right, and with gestational diabetes, I see a lot of people with gestational diabetes. We actually usually have them test their blood sugar 2 hours after a meal. Fasting in the morning, 2 hours after a meal, because of this insulin resistance. You want to see how much the blood sugar has risen after the meal, and if that blood sugar, is too high after meals, there is one oral medication that can be used, but generally it's insulin. So what we usually do, again, a consistent carbohydrate diet, exercise lowers blood sugar levels, and insulin, as I said. So, I talked about a hemoglobin A1C before. What is a hemoglobin A1C? And patients ask me this all the time. They say, well, I test my blood sugar and I get 150 or 200. What are you saying, 6%, 7%, 8%? Well, what happens is that sugar in our blood attaches to our red blood cells. And we make new red blood cells about every 2 to 3 months. That's why we can donate blood, for instance, every 2 to 3 months. And so that's how they can calculate how much sugar has been in your blood for the last 2 to 3 months. And so then there's something called an average estimated glucose. And so if this is your A1C level, this is your average blood sugar. So I told you that an A1C of 6.5% or higher diagnoses diabetes. What are the targets? Well, according to the American Diabetes Association, it's less than 7%. The American Association of Clinical Endocrinologists even wants that target level. They want it to be like 6.5% or lower. Okay. And so, yes.
Less than 7% is a very aggressive goal.
Yes.
Because I thought the ADA was saying now about 8%.
No, that's the American College of Family Physicians who are saying it. And there's a lot of discussion that the reason why they're saying it is because it's very difficult. They see people every 15 minutes. They don't have time to review logs and do all of that. So
metrics.
What's that? The drugs.
Part of meeting metrics for
Right.
insurance companies.
Exactly. Payment is based on A1Cs, and 7% is very hard to reach. The other thing to mention about A1C, so this is their targets, but they always say it's individualized. If we have a younger person who was just diagnosed within the first few years, you want their A1Cs 7, 6.5. If you have a patient who's had diabetes 20, 30 years, has complications already, we're happy if it's 8, 8.5. So, but this is, the published targets for the A1Cs in a person without complications of diabetes. So, and what are their glucose targets? When they're tested, I know that we're going to talk about glucose testing at home later on, but if a person's testing their blood sugar, again, this is ADA, is 70 or 80 to 130. If you do it 2 hours after you start eating a meal, and that's important, after you start eating, because some people take 10 minutes to eat and some people take 30 minutes to eat. So it's 2 hours after you start eating, less than 180, and at bedtime about 110 to 150. So now, any questions before I go on? So I mentioned, there's also other types of diabetes, secondary diabetes, that can be related to steroids or things like pancreatitis or Cushing's disease. There's all sorts of things, late onset autoimmune diabetes, many, many different types of diabetes. But any questions before I move into complications about anything else? Yes?
Just a general question. Once you have diabetes and you start insulin, there's no turning it around?
Absolutely not. And the reason why I say that is it's interesting. I've seen, because I've been in the field so long, it used to be that when a person was diagnosed with diabetes, they would say, try diet, and if that doesn't work, we'll put a pill, and if that doesn't work, we'll do another pill, and if that doesn't, and by the time a person was on insulin, they had complications already. So now, even in the hospital, if a person has an A1C of 9-10%, we will send them home on insulin. And the whole idea is that person has so much sugar in their body that if you just throw one pill at them, that's not going to do anything. So what we want to do is get their blood sugars down. They might be on insulin at home, like the long-acting insulin that you'll talk about later on, Lantus or something like that. They might be on that with some pills, maybe for 2-3 weeks. Their blood sugars start coming down. Then they take away the insulin. Then with losing weight and exercise, their blood sugars go down. They can take away another pill. So, it's a totally different way of treating it because, again, part of some of these studies have shown that if you can keep the blood sugars down within the first 5 years, you can even have some cardiac benefits and everything. So that's what we see in the hospital all the time now. So, I was going to ask you a question on, okay, so the question, diabetes is the leading cause of adult blindness, amputation, kidney failure. Is that true or false?
True.
It's actually false. Uncontrolled diabetes is the largest cause of those things. Controlled, well-controlled diabetes, you don't have to develop these. So that's the key takeaway with this A1C. And I do this slide in the hospital when I'm teaching residents, when I'm teaching, all, nurses and dietitians and everything. Because it is, there were 2 very large trials many years ago called the UKPDS and the DCCT. And they were trials, it was multinational trials, lots of people. And that's where this A1C number of 7% came from. They found that people who could keep their A1C at 7% or lower did not develop these problems or delayed way until they were older. So that's the key takeaway I tell people, because so many times I see people in the hospital and they say, well, my mother, died of diabetes, they lost their leg, they developed this. So it's kind of like what we call the legacy effect, that you think this happened to your family member, and so this is going to happen to you no matter what. It's kind of, and we talk about these studies, we talk about the A1C, and we talk about that these things don't have to happen. It gives people hope, which is really important. Over time though, high blood sugars can lead to heart disease and stroke. And, when you have stroke, your blood vessels and your nerves and everything are damaged from constant variation, high blood sugar, low blood, That's actually even worse than high blood sugars all the time, is jumping up with the blood sugars. They call that glycemic variability. And the other one is kidney disease. That's called diabetic nephropathy. And over time, with uncontrolled diabetes, that can occur. Another thing, eye problems. I'll talk about that. We call it retinopathy and nerve damage, neuropathy. So, talking about the foot, it's one of the things I see most often in the hospital. So, Jack was talking about the nerve damage, the numbness and everything. That's called neuropathy. Now, people can develop neuropathy for other reasons besides from their blood sugars. Poor circulation can also cause neuropathy, or can, even if a person has good blood sugar. So the problem is those pins and needles or the numbness. So if a person doesn't, we teach people to look at their feet every day, to take a mirror, to look at the bottom of their feet, because I see it all the time. People come in, they stepped on something. It's the whole idea, they step on a nail. Well, I'm telling you, people step on nails. Construction, we see a lot of construction workers and everything. They have something, they don't really feel it, they don't look at it. Then all of a sudden they look at it and they put little something on it. But if you have high blood sugars, it can develop into ulcers. And these ulcers, if not treated properly, can develop into amputations. Sometimes they start with a toe, or they start with a part of the foot, and so it's really a very sad thing, because so much of it is preventable. So the next complication we'll talk about is the eyes. Again, when you have these high blood sugars that are coating all the blood vessels and the nerves in the eye, this can cause diabetic retinopathy, and eventually, untreated, it can lead to low vision and blindness. And diabetic retinopathy actually has 4 different stages. And, so as each stage, sometimes there can be some laser treatments done and things like that, but that's why it's so important that we tell people you need to see an eye doctor once a year. Same thing I didn't mention with the feet. They need to see a foot doctor once a year. If they don't have health insurance, the clinic will do this also. But it's so important to tell people this. And another thing as far as glaucoma. Glaucoma is an increased pressure within the eye that can result in the optic nerve problems and gradually a vision loss. Kidneys. It's so sad when you see this. Our kidneys take all the wastes in our bodies, filter them through, get rid of some, and the others, they take care of the other waste in the body. But unfortunately, again, there's about 5 stages of kidney disease. 5 stages. And as kidney disease progresses, the kidneys can no longer filter out and get rid of these waste products. And so they build up to these poisonous levels, and you can see it in lab testing. So the ultimate, at stage 5, you have end-stage renal disease, which necessitates dialysis, either hemodialysis, peritoneal dialysis. So kidney disease is something that, again, is getting blood sugars, at a good level, A1Cs, it can really help prevent this. Actually, if a person has diabetes, they are already considered at risk for heart disease. They have heart disease. So, part of it, which came first, the chicken or the egg, and I'm talking about type 2 diabetes now. Because this insulin resistance, a person usually has high blood pressure, they usually have high cholesterol, and all of this, they used to call it metabolic syndrome. You don't really hear that term as much, but so this person actually likely was developing heart disease even before they diagnosed the diabetes. But we do know that uncontrolled blood pressure can lead to strokes. And also the uncontrolled blood sugar. And I can say from a personal, I have a brother-in-law who at the age of 55, his A1Cs were running 12 and, it was difficult getting him. I used to talk to him, his daughters would call me, I'd give him meters, I'd do everything, and he developed a stroke. And his blood pressure, and he's actually had 2 strokes. And so these kind of, I can't stress enough, it just pains me, to see this happen when you have these A1Cs. A lot of times when a person is not controlling their diabetes, they're not controlling their blood pressure either. And they're not controlling their cholesterol. So all of these things are very, very important. So, we talked about the types of diabetes. There are other complications of diabetes that I didn't even mention. There's also, the neuropathy is called peripheral neuropathy, but you can also have autonomic nervous system neuropathy. Now, what's autonomic? That's our nerves inside our body. I don't know if anyone has ever heard of gastroparesis. That's the slowing of the digestion. That is actually a complication of diabetes also. And there's a whole host of problems. Blood sugars get all out of whack because the digestion is all different and everything. Another thing, I mean, I haven't talked about hypoglycemia because I believe somebody else is talking about, are you talking about hypoglycemia at all?
I don't really have it in my talk, but I could say a little something if
Okay.
you care, if you want to.
I mean, I'll talk about
Yeah.
this. Hypoglycemia, we don't really consider it a complication. It's a side effect of medications, of certain medications and diet and everything. Low blood sugar or hypoglycemia is a blood sugar less than 70. Sometimes people, so what are the symptoms? Sometimes people feel a little dizzy, lightheaded, hungry, sweating, fast heartbeat. Can you give any other symptoms of hypoglycemia, Jack?
Yes, fainting and having to go to the hospital because
Right.
the hypoglycemia it's bad. High blood sugars are bad. Hypoglycemia is worse.
Mhm.
It's absolutely worse because, and very often, it's when you don't eat enough. You're either not eating enough or you're taking too much insulin.
Right, well, so hypoglycemia, and the funny thing is, so what you have to do, you have this blood sugar less than 70. So what you need to do, we teach people, if they have a meter, if they have these symptoms, test their blood sugar so they can see what their blood sugar actually is. And if their blood sugar is between 50 and 70, we tell them to take about 15 grams of a fast-acting carbohydrate, like juice, like regular soda. They sell glucose tablets. But not to eat a cookie or something like that, because a cookie or a granola bar or something has starch in, has some fat in, some protein. Fat and protein don't raise your blood sugar. Starch takes longer to digest. So you take a fast-acting carbohydrate, and then we teach them the rule of 15. You take 15 grams of carbohydrate, and you retest in 15 minutes. And if your blood sugar still isn't high enough, you take another 15 grams of carbohydrate, and you retest in 15 minutes. If for some reason your blood sugar is less than 50, I mean, there are people who have a blood sugar 40, 45, and they're, they feel it, but they didn't feel that their blood sugar was that low. Twice as low, twice as much. You give 30 grams of carbohydrate, 8 ounces of juice, 8 ounces of regular soda, 4 to 8 glucose tablets.
So are you supposed to keep, is it advisable for someone to keep their blood sugar between 70 and 100 then, or what's like the level?
Well, the recommendations loosely are about 70 to 130, 80 to 130. But again, it has to be individualized. It's a fine line. A lot of times I tell people, I'm just happy if you're below 150. Because with some people straddling that 70, 80, but I think the most important thing for people to know is actually what to do. People end up in the hospital because them or their family members didn't know how to treat it properly. If you, again, they just gave them, some crackers or, this or that. They didn't retest the blood sugar. Because when you take a blood sugar, it's not that moment in time. Your blood sugar, it's just that moment in time, but your blood sugar could really be falling fast. So that's one of the things that's important. It's not technically a complication of diabetes. It's a complication of balancing exercise, eating, your medication, stress, and all of that. Yes?
Just a quick tidbit. The best thing to carry, as if you're in transit, you're in the car, is always have glucose tablets. I have diabetes and I have type 1, and I can tell you that I know every trick of the trade, but I will tell you the most important thing is to carry tablets so you have on hand, or little juice packs, small baby ones that are not too many carbs, right?
Right.
Fast-acting carbs can raise you too high, and with a low, you can get a high.
Right.
So we have to be careful.
Right.
But I like the glucose tablets, because if you have 3, I think it's 3 or 4, it's 50.
It depends on the
Right.
manufacturer.
Right.
That's why we always say, look at the nutrition facts
Right.
label and see whether it's 3 or 4. Some of them are a little smaller, some of them are a little larger. But that's what I recommend, is that people carry their glucose tablets.
Are they over the counter?
Yes,
Yes.
absolutely.
And inexpensive.
Yes,
It's like
it's-
$1.50 or $2.
Yes.
Yeah.
Yeah, a little tube of 10.
Yeah, yep. So very important. But another complication when we start talking about this autonomic nervous system is some people have what we call hypoglycemia unawareness. They do not feel their blood sugar going down because with their nerves in their fight and flight system, they don't feel it. So that's something, again, that we, ask people, especially if they have a tendency to this, to make sure they test their blood sugar, more frequently, and make sure and now, of course, they have continuous glucose monitors, which are really wonderful. That's beyond the scope, of what I was talking about, but, I've been doing this a long time. I could talk all day about, everything. They have continuous glucose monitors that work with insulin pumps. They have a new one that I'm sure everyone has seen on TV called a Libre. And people are asking me all the time, I don't have to prick my finger anymore. It's a continuous glucose monitor that you put under your arm. And when you want to see your blood sugar, you just scan, your device there, and it will also do a readout so people can also see what are their patterns. Am I always going low at night? Am I always going low with this? And so they and the physician can adjust medications if needed and adjust eating if needed. So that's been, again, from the days that we didn't even have meters to the better meters to now these continuous glucose monitors. We've come a long way. So just the last slide, treatment of diabetes. So in general, meal planning. That's the number one thing people ask about. They're so afraid now, what can I eat, what can I eat? So, and as a dietitian, I will often tell my fellow dietitians, the physician can order the most elaborate medication regimen, but if the person doesn't know what to eat, that medication regimen is going to fail. So meal planning, and we don't call it a diabetes diet. There's no diabetes diet. It's a healthy eating plan that would be good for all of us to follow. It's consistent carbohydrates throughout the day from meal to meal. Medication. We're going to talk about medication later. Exercise. Exercise can lower blood sugar, so that's very important. Before people exercise, they may have to check their blood sugar. They may have to have a snack before. They may have to check their blood sugar in between. So exercise, and then you check your blood sugar to see how all of this is working. You don't want to wait for 3 months to see what your A1C is. You want to have this information. And I tell people, it's not a good, or don't refer to your blood sugar as good or bad. Oh, my blood sugars are so bad, they're so good. It's information for you to act on. It's showing you trends, it's information. It's not that they're bad or they're good. And then education. There was a recent study that only 33% of all people with diabetes, and again, we have people with diabetes here, we don't call them diabetics. We call people with diabetes, you don't call a cardiac patient a cardiac. That's a adjective. That's not what a person is. It's a person with diabetes. So people with diabetes, only about 33% have ever had formalized diabetes education. That's why we're having so many problems. Diabetes, and that's why this program is very exciting, because there are people who cannot afford to go to outpatient diabetes centers. They can't drive. I have people in the hospital, they're interested, but they have no one to drive them. So we can help them via the telephone. They might have a computer or a cell phone that they can look at things. So with diabetes, understanding diabetes is one of the most important things that anyone with diabetes can do to really prevent their complications and really lead a healthy life.